Hi everyone, welcome back to the TinyDocs Talk podcast series, Pediatric Interview Edition, your source for the clinical thinking station or clinical reasoning station of the pediatric training interview in the UK. This is brought to you by the British Sudanese Association of Pediatric and Child Health, or BSAPCH in short. I'm your host, Guiria Ibrahim, and today we have our presenter, Guiria Ibrahim. She will present a real life demonstration case of clinical thinking station. So, without further ado, let's dive into our episode.
So it looks I'm dealing with a severely critically parent child. So I have to inform my senior and I have to prepare my area and to delegate the role of my team. And I ask one of the team to bring the protocol of parent. Then I have to manage this patient in resus room. I will connect him immediately to the cardiac monitor, pulse oximeter, and I will apply for him 100% oxygen by non-rebracing mask. Then I will approach this child by an ABCD approach. I will start by the airway. I have to ensure airway patency because inhalation injury or scald burn to the mouth and the face can compromise airway. So I have to inform the anesthetic team because I have to secure the airway early. Then I will go to the breathing and I will apply for him a high flow oxygen and I will assess the breathing in terms of the respiratory rate, chest expansion, and to auscultate to the air bilaterally. And I have to exclude that is there is no circumferential burn in the chest or abdomen because it can cause mechanical restriction of the chest movement. Then I have to go to the circulation to assess the circulation, it is adequate or not. I will assess the peripheral and central pulses, capillary fill time, color, and blood pressure. So I have to insert two large bore IV cannulae and to take blood for full blood count, blood gas, carboxyhemoglobin level, use an ease, coagulation profile, and blood for group and safe and cross matching. Then I have to expand the circulation. If there is any evidence of hypovolemia, I have to give him a bolus of IV fluid, and also I have to consider to give analgesia in terms of morphine because this will be very painful. So I have to move to assess the disability in terms this child may is having altered level of consciousness due to hypoxia, hypovolemia, or due to head injury. So I will assess the Glasgow Coma scale by AFBO and to check the pupils and to measure the blood glucose. If this patient is hypoglycemic, I have to give him a bolus of dextrose 10%. Then I will move to the E to expose this child to see if there is any hidden parent area like in the perineum or any other area, and I have also to measure his temperature, and those parent child they are susceptible to lose the temperature easily, so I have to cover this patient by a blanket. Then I have to update the family. I will ask about the history of the event in details. What is the cause of the burn? What is the material of the burn? And for how long? And if there is any history of inhalation and smoke, it is confined area. I will ask also about any past medical history. If this patient is having chronic or immunocompromised patient, I will ask also about any medication. And then I have to do a secondary survey in terms of I have to manage this child to assess the burn area in terms of the to measure the percentage of the area. I will use like an emergency application or the body chart. I will assess and measure by the child bulb to assess the percentage of the burn. Then I will assess also the severity and the depth of the burn in terms is it superficial, dermal, mid dermal, or deep dermal, or it is partial thickness or full thickness. I have to involve the surgical team to assess also the burn Then I have to give this child fluid. I will give him the fluid according to the modified Parkland formula, and plus the maintenance. And I have to give him an analgesia because this is very painful. I will give him IV morphine. I think this is suitable. Then after that I have uh, to do a wound care. We have to put and cooled it for 20 minutes and then cover it by non by non-adhesive sterile towels or sling film. I have to consider to update the plastic surgery. So I have also to consider to give prophylaxis, but also in my mind that if there is any safeguarding issue, I have to contact with the social worker. Then also important thing we have to ask about the history, because maybe there is possibility of carbon monoxide poisoning. So we have to measure the carbon monoxide. If the carbon monoxide level more than 20%, we have to give him and hyperbaric oxygen. And we have also to discuss with the burn area if there is any special, there is we have to manage this child in the special burn unit. I have to call the retrieval team to transport this child to the nearest tertiary burn center. If there is inhalation injury, if there is chemical injury, if there is chemical burn or inhalational burn or electrical burn, if there is partial sickness more than 2% or there is deep sickness more than 1%. Also, if there is burn to the special area like soul, palms, face, and perineal area. If there is also a burn associated with significant comorbidities or burn associated with trauma, we have to manage this child in the burn center. Then we have to do a debriefing session to our team to improve our performance and to avoid our next in the next
As we wrap up today's episode, me and Bisab CH would like to extend our thanks to our presenter Guiria Ibrahim. Thank you for sharing your insights with us. We hope this episode has provided simulation-like guidance for the clinical thinking station in pediatric training interview. Remember, our journey does not end here. Be sure to check out the rest of our podcast, our YouTube channel, our website for more information. Your feedback is valuable. We invite you to reach out and share your thoughts, question, or suggestion. Together, we can continue to improve and provide content that meets your need. Thank you for tuning in, and until the next time, stay curious and keep learning.